So next up is a neurodegenerative disorder that would be Alzheimer's in comparison with Parkinson disease and Huntington's disease. In Alzheimer, the neurotransmitter that is deficient happens to be acetylcholine. The area where this acetylcholine deficiency is present is mainly the temporal lobe. Deep in the temporal lobe, we have hippocampus. Hippocampus is the seat for memory. So nucleus of Maynard Bezalis is the one that gets basically affected, and therefore loss of memory or like amnesia is the early manifestation. For Parkinson disease, anyway, you know it is substantia nigra and it's a dopamine deficiency. So he will ask you for Huntington's disease. In Huntington's disease, dopamine levels are more. Yes, guys, dopamine levels are more. So what I can say is that if by mistake levodopa is given to patients of Huntington's disease, it will cause worsening of the patient because already dopamine is more. So if he says what is the neurotransmitter that is less here, then answer is GABA, which is the inhibitory neurotransmitter, and this mainly affects the caudate nucleus, because of which involuntary movements would be developing. Dopamine is more and inhibitory neurotransmitter is less. So that explains why one of the major hint in the question or the presentation will always say the word chorea. Chorea is like choreography, dance like movements that would be present. Like I am at the moment, let me say, writing in front of you. So with one hand I'm writing, my other hand is stable on the table. But suppose my hand is showing a dance movement, and obviously I'll feel embarrassed about it. So lots of time I will try to conceal it by putting my hands in my pocket or keeping my hands under my thighs. So patients of Huntington's chorea, you will notice in consultation, will be trying to conceal the involuntary movements in the hand by putting their hands in their pocket, or maybe trying to put their hands below their knee, below their hip joint, or below their like thighs primarily. So I'll describe the clinical manifestations more in detail, but I just wanted to give you a heads up with respect to the comparison: acetylcholine deficiency, dopamine deficiency, and a dopamine excess with a GABA that is lesser. That explains the chorea manifestation occurring here. In Alzheimer disease, the main area of the brain that is affected is nucleus of Maynard Bezalis, which I said is in the temporal lobe, which is the seat of memory. And then he will also ask you here what are the bodies which are present and what is the protein. So you would be aware from your pathology classes that the bodies which are found in the cytoplasm of the neurons in these patients are what are called as Hirona bodies. The chemical composition of Hirona bodies would be tau protein. That is why in pathology class, the teacher will call it taupathy. Alzheimer is written as taupathy. In Parkinson disease, we have a dopamine deficiency. Substantia nigra is the one that is affected. The bodies which are present are called as Lewy bodies, and the protein that is involved is called as alpha synuclein protein. So therefore, in a lot of pathology questions, Parkinson disease is written as alpha synucleinopathy. In contrast, when we talk about Huntington's disease, there the protein that is involved is huntingtin. It's not Huntington. The protein that is involved there is huntingtin protein, and this is rich in polyglutamine repeats. In fact, the protein is rich in polyglutamine and ubiquitin. So the words have to be remembered: ubiquitin, polyglutamine. Polyglutamine, polyq repeats, and ubiquitin positive is like the technical way of describing it. Let's remember the proteins once again: tau protein, alpha synuclein protein, huntingtin, and ubiquitin. Huntington and ubiquitin, which is written as like ubiquitin positive rich in polyglutamine repeats. Now, none of these disorders would be having a genetic basis. Like in Alzheimer or Parkinsonism, it is not a guarantee that if person is having it, his son and daughter will be having it. But in Huntington's disease, it is a guarantee that if the person is having neurological disorder, then his son, daughter, grandson, great grandchildren all will be having neurodegenerative disorder, because it is autosomal dominant in inheritance. So lots of time, like these questions which give neurological findings, if they themselves mention that the father, grandfather, great grandfather were also having some known or unknown neurological illness, by default the question becomes Huntington's chorea. The defect here is on chromosome number 4. Then he will say what is the the codon repeats that happen, or CAG segments get repeated again and again. See, our genetic code is variable. If CAG segment on the Huntington gene starts repeating again and again more than 40 times, then when this abnormal protein, that is huntingtin protein, is produced. The highlight of Huntington protein is it is having ubiquitin positivity. And the more important thing is anticipation. That means in every generation, the disease will occur and will occur little earlier. Like suppose grandfather had neurological manifestations at 60 years of age, then father will have neurological manifestations at 50, and the grandson will have neurological features appearing at 40 years of age. So in none of the remaining neurodegenerative disorders will you have such significant family history. And even if like father had Parkinson, son also had Parkinson, then the age of presentation will remain almost the same. It's not that it will come a little earlier. At this point of time, I also want to bring to your attention a clinical like question that came in FMG exam where they gave these clocks, and they said that the patient is not being able to draw this clock. Like for example, this is when patient came first time, that is in 2010. Then the patient came like at 2012, then patient came in 2014. I'm just giving an example here, it can be any year basically. So like he's making a mess of the diagram with respect to the time. So this is what is called as a clock face test, and clock face test tells me that the patient is not even, like you told him to make a particular time, and the patient is not able to make that particular time. Like you had specifically instructed him to make the time of 11:10. You can see one need on 11, other and 10. So I had asked him to make a time of 11:10, and he forgot the time also, he forgot the orientation also, and later is making a mess of the diagram. So the question simply gave this like this three images of clocks in different years, and he said clock face test is used for diagnosis of, your answer would be given as Alzheimer's disease, that is it is helpful in diagnosis of dementia. So one of the manifestations that is seen in these patients is amnesia, that is forgetfulness slash dementia. In fact, I'll first put a broad term. Amnesia can have like short-term memory loss, long-term memory loss. So a broad term I just want to say is clock face test is used for evaluation of dementia. And now I'll be writing 4 A's of Alzheimer disease which they love to ask. The first A would be that the person will have amnesia, where first short-term memory will be lost, like he will not remember his mobile phone number, or like I can say he forgot. Like if I ask you, what did you have for lunch today, what did you have for dinner today, so like you can tell whatever you ate short time ago. Here the person will be having like forgetfulness, that would be amnesia. That is short term memory loss initially, then long term memory will also be affected. That's where he'll not remember where he lives, what is his son's name, daughter's name, birth dates, etc. Then the person will have damage to the dominant parietal lobe. Remember I told you dominant parietal lobe damage causes aphasia. Then the damage will occur in the non-dominant parietal lobe. The atrophy of the non-dominant parietal lobe will cause apraxia. That would be like constructional apraxia, so that visuospatial skills would be lost, like he cannot draw geometrical shapes. And lastly, the person will be so bad that he might even urinate in his pants. He may urinate in his clothes, but he will make no attempt to clean himself. See, if a person accidentally passes urine, maybe by chance, then person will at least feel embarrassed and will try to clean himself. Alzheimer's disease patients have gross apathy. They have like total lack of self-care. Like this guy might be wearing the same pajamas which are soaked with the urine and fecal matter of this person. He's stinking like anything. His son and daughter is saying, sir, I don't know, my father was like so educated person, he's a retired government civil servant, and now he has become so unhygienic that he urinates in the living room, just like a little baby urinates everywhere. Now this old man is urinating in the living room. So his daughter is very crossed with him. Dad, what are you doing? Toilet is the place where you're supposed to urinate. You're urinating in the living room. The old man will like make no attempts to clean himself, and he might do it again. So lots of time in India, houses are small, and like one 2 BHK apartment. If it's gonna be stinking, they might throw the old man out of the house. So you might have gone to a temple sometimes in your life, or you might have gone to a mosque for a prayer. After prayers, we usually give food to poor people. So you will come across an old man sitting almost naked or semi-naked. There are flies around him. He's stinking bad. People are keeping food in front of him. He does not even know how to eat the food. So as a young budding doctor, you thought, okay, let me have some empathy for him. You try to feed him. You picked up some rice with a spoon and try to bring the food near the mouth. He will not even know how to open the mouth. You feed a baby also. Baby will open his mouth. Here you're trying to feed him. He's not even opening his mouth. So you forcibly opened his mouth, put food in the mouth. He does not know how to chew. The man does not know how to eat food. He does not know how to chew. And in the later part, these patients can die because of aspiration pneumonia. One of India's former prime ministers, the man who gave us the nuclear bomb and ensured that nobody attacks us like America does random attacks, right? Those countries that lack a nuclear bomb, right? The man who got us the nuclear bomb, actually, those big megatons wale, was Atal Bihari Vajpayee. He developed Alzheimer's disease. We lost him unfortunately because of the complications, that is aspiration pneumonia. This is one of the leading causes of death in both Alzheimer's disease, Parkinson disease, and even in patients of Huntington's disease also. These three neurodegenerative disorders cause death due to the impact that I have currently mentioned. Then he will say, what is the screening test that is done for this condition? So screening test is mini mental score examination. Mini mental score examination is used for identification of dementia. The score of the patient in this 30 item test should be less than 24. That's itself a question, that a person should score less than how much in a mini mental score examination to say dementia. Answer is less than 24. If the score is between 21 to 24, we will say mild. If the score is between 10 to 20, we will say moderate. If it is less than 10, we will say severe. So we have mild dementia, we have moderate dementia, and then we have is a severe dementia for MMSE per se. But this is not the investigational choice. The investigational choice for diagnosis of this condition should be answered as amyloid PET scan. The investigational choice is not a mini mental score examination, guys. It's a amyloid PET scan. If amyloid PET scan is not in the options, if amyloid PET scan is not in the options, then the second answer that you will be giving after this is again a PET scan only. But then I will like to say that, like, overall, if I look at it, then PET, because PET talks about metabolic activity also, na? And like the parts of the brain that are affected in this condition are mainly the parietal lobe and the temporal lobe. In Alzheimer, don't say that all the lobes of the brain are involved, guys. It is mainly the parietal lobe and the temporal lobe in the patient that might get affected. In the older versions of the app, I was mentioning plain PET scan, or I was saying the word functional fMRI. It is chota f, not flare. I'm saying it is not flare, FLAIR. I'm saying chota f is functional MRI. It is F, chota f stands for functional MRI that can be done for these patients. Though there are multiple drugs used for it, because this is a comparison. So the drug of choice that we use for management of this condition is donepezil. And I would like you to read about lecanemab, and then galantamine and memantine, a couple of other drugs from the pharmacology perspective. In fact, one of the drugs that I would still, be tempted to write it, because this lecanemab is a drug which basically prevents the development of Alzheimer's disease. This is a drug that's not used for treatment of Alzheimer, but it is used to prevent the conversion of mild cognitive decline into Alzheimer. The name is lecanemab. How this drug works is that it destroys the A beta amyloid deposition that is occurring in the neurons of this patient, or A beta deposition in the brain that occurs. Lecanemab is not used for treatment. It is used for prevention. What this drug does is that it prevents or slows down the conversion from mild cognitive impairment. MCA stands for mild cognitive impairment to development of full-blown dementia. So I would again like to highlight that lecanemab as a molecule that which the pharmacologist would have said is not for treatment of Alzheimer's. It is to prevent the development of Alzheimer's disease. So you can see that we have gone from a stage where we used to wait for neurological manifestations to occur to prevent development of derangement. Like, we are trying to slow down the progression by causing destruction of A beta amyloid that is getting deposited in the brain of this patient. MCA stands for mild cognitive impairment, and we want to prevent this conversion, mild cognitive impairment, into development of full-blown dementia. So at the moment, I've described the important features with respect to AD, that is Alzheimer's disease, and now I will focus on features for Parkinson disease. Here, the mnemonic to be remembered is not 4 A's, but the mnemonic to be remembered is TRAP. TRAP are features of Parkinson disease. The earliest motor manifestation. The question will say, what is the earliest motor manifestation in this condition, where substantia nigra is damaged, where Lewy bodies are present, alpha-synuclein protein is present, is development of resting tremors. These tremors are not present in both the hands. They are present in one hand only. That is, it will be asymmetrical. And even the frequency of these tremors is a low frequency tremor. So most of the time, we will say 4 to 6 hertz resting tremor present in only one hand. And the tremors are between the thumb and the index finger. In India, if somebody is counting like this, the family members will say, our father keeps on counting paisa paisa karte, right? But like in America, the word that is used for it would be called as a pill rolling tremor. So in PD, you have is pill rolling tremors. There would be resting tremors, asymmetrical only in one hand, and the frequency is 4 to 6 hertz. It's a low frequency tremor. The body will become very tight. There would be a hypertonia, that is development of rigidity. There would be like rigidity or hypertonia present in this patient. Instead of like trying to make it sophisticated, he may write words like cogwheel rigidity. Then would come one of the must-have criteria for diagnosis of this condition, that patients of Parkinson will become very slow to the level that in the morning when the person had to go to the washroom, by the time he reached the washroom, urine was passed. Bradykinesia, that's a must-have criteria. In fact, in the later part of the disease, the person might become wheelchair bound. Like the biggest boxer of all times, Muhammad Ali, was a patient of Parkinsonism. In 2016, in the Rio Olympics, when he was called on the stage, he did not walk up to the ring. He was brought on a wheelchair. And then they put a mic in his face and they said, sir, can you just say a hello to the whole world? Because the opening ceremony of Olympics is watched by millions of people all over the world. The man could not say even a hello because of the rigidity of the vocal cords, akinetic mutism. Alphabet A I'm highlighting is because Alphabet A I'm highlighting at the moment is because if he says which of the following is a must have criteria for diagnosis of this condition, then must have criteria is bradykinesia. I've underlined bradykinesia. And the severe version of bradykinesia is what is called as akinetic mutism. In fact, one of the best industrialists that India had, the guy who created TCS, right? Tata Consultancy, Tata Defense Systems, his name is Ratan Tata. We lost him again, right? A couple of years ago. And Ratan Tata, sir, you will notice that he developed that peculiar, like there are no verified credible reports, but if you see any video of him towards the later part, he was having that stooped posture. Like if I just significantly draw it like this, I can say that the person of Parkinson disease, let me just refresh it or like redraw this patient of PD. When you and me walk, we have a lot of flexibility at our knee joint and ankle joint. But in Parkinson disease, there is no flexibility at the knee or the ankle joint. The patient will walk, then the person would be bent forward like this. The person would be bent forward like this. And there would be no automatic arm swing. Like when we walk, no, we have that automatic arm swing here. No automatic arm swing would be present. So the body of the patient is bent forward. There is no automatic arm swing. When he will walk, it would be like as if like the feet are literally rubbing against the ground. So the gait abnormality that we get in this condition is what is called as fascinating gait. And along with this fascinating gait, when you look at the face of these patients, it would be an expressionless face. So we call it masked faces. And if this person is walking alone, like this person is taking a walk in the park, there is a small obstacle in front of him. If you and me have a boulder or an obstacle, we can jump over an obstacle. This guy might slam and fall. That is why I mentioned the word postural instability. If he says what is the investigational choice for diagnosis of this condition in a comparison basis, like if he says what is the best test for confirming the diagnosis, though Parkinson is a clinical diagnosis, we can do a test by the name of PET-DOPA and we can effectively manage our patients. As far as the treatment of this condition is concerned, the standard drug treatment will be in the form of levodopa and carbidopa. Levodopa, if it is given alone, then it will be converted in the blood into dopamine that will cause vomiting, that will cause postural hypotension. So levodopa is never available alone. It is always available as a fixed dose combination with carbidopa. It is a peripheral decarboxylase inhibitor. It will inhibit the conversion of, like, it will not allow dopamine to be formed in the blood because I don't need dopamine in the blood. I need it in the brain. So levodopa carbidopa is always available as a fixed dose combination. The problem is that both of these medicines have a short duration of action. So to increase the duration of action, we add COMET inhibitors. COMET, full form I'll not write, it is catechol O methyl transferase inhibitor. You know it from pharma. What this medicine does is, why it is added is because it increases the duration of action of this levodopa carbidopa combination. The name of the molecule, COMET inhibitor, is entacapone. If he says like, why are you adding entacapone? Then the rationale behind adding entacapone is to increase the duration of action of levodopa carbidopa combination. The drug used is called as entacapone. Then lots of time, these patients, when you give this medicine, when levodopa carbidopa is given, when the drug levels will spike in the body, patient will start developing choreiform movements. Earlier, patient was having bradykinesia, but now when the dopamine levels will suddenly spike in the brain, then patient can develop choreiform movements. That is the side effect of levodopa carbidopa, that suddenly, like when the dopamine levels will rise, choreiform dance-like movements will occur in the hands of the patient. Earlier, there was no movement, now movement is occurring in exaggeration. So to suppress these choreiform movements, which is one of the side effects, he has asked what drug can be used in this patient. This is an anti-flu drug, guys. This anti-flu drug is used for treatment of influenza, that is called as amantadine. Amantadine is given in Parkinson disease patients. Why? Because it suppresses the side effect of choreiform movements, and this choreiform movements is a side effect of which drug? Levodopa carbidopa combination. I'll repeat the points once again, guys. The question was very simple. The question was in fact an FMG exam question. He said which anti-flu drug is useful for management of Parkinson by decreasing the choreiform movement. So he done 50% work for you. उसने खुद ही बोल दिया यार anti-flu drug. So what more easier do you want, right? I mean, that is anti-flu drug is amantadine. It decreases the side effect of levodopa carbidopa combination. It decreases the choreiform movements which are occurring due to the combination of levodopa plus carbidopa. L is for levodopa, C is for carbidopa. If I want to decrease the side effect, it is amantadine, and to prolong the duration of action, I give entacapone. So two pharmacological aspects here. How do you prolong the action of the medicine? It is adding entacapone. How do you prevent the peak dose dyskinesia? Either he will use the word peak, when the drug levels will rise, he will say peak dose dyskinesia, or he might write the form decrease in the choreiform movements. In fact, I'll write the classical word only, so that, because in MCQ he will use the classical term also, but I've told you the gist of it. Choreiform movements, he will say when the drug levels will rise, peak dose dyskinesia. This means involuntary movement is started in the patient. Earlier there was less activity because dopamine deficiency was there. Now due to the spike, you are having more activity. We call it peak dose dyskinesia, which basically needs to be reduced. So two technical details at the moment for Alzheimer and Parkinson disease. Now we'll talk about Huntington's disease. Huntington's disease is ultra gonna be easy, because here he will begin with like a person is about 50 years of age and he will say he's having dementia. Last time I mentioned a 30-year-old man with dementia, I had told that he had also have myoclonus, startle myoclonus, and he had consumed that poor quality beef. Remember, that was variant Creutzfeldt-Jakob disease. Today I'm again beginning with dementia, now not at 30 but at 50. I mean, you read 50-year-old man with dementia, you don't think Alzheimer. No, Alzheimer will occur in 80 years of age. Here it is much younger patient, and then he will himself say chorea. And then he will himself say the patient is having recurrent falls. So dementia, chorea, recurrent falls, and then obviously, like, to make you think that it is Parkinson disease, he will write bradykinesia also. He might write the word rigidity also. But what I want to say is that, like, this khaskar, the word rigidity, the word rigidity will be written in questions of even Huntington's disease, and that makes a lot of guys think that it is a Parkinson disease question. But in Parkinson disease, you have recurrent falls, understandable, you have rigidity, but you don't have a chorea and you don't have a dementia, right? I mean, that is like straightforward pointers which tells you that the question is not of Parkinson disease. So 4A's versus trap versus the manifestations of chorea. I mean, the chorea word itself is self-explanatory, or you might say dance-like movements in the hands. Patient is trying to conceal the movements by keeping his hands in his pocket, is keeping his hand under a thighs, no, ऐसे हाथ thighs के नीचे हाथ छुपाने का कोशिश कर रहा है. So that's like the choreiform movements in the hands and the feet of this patient. The investigational choice in this condition is a MRI, and this MRI head will be showing atrophy of the caudate nucleus. This disease mainly causes caudate lobe atrophy. I have drawn the caudate lobe once earlier on a CT scan adjacent to the lateral lobe of the brain, and now for the treatment of this condition, I will be giving a dopamine depleter. Remember, dopamine is more in the body of this patient. So the dopamine depleter that I'll be using for management is tetrabenazine. And suppose you say, sir, I don't remember all this, how do you expect me to solve the question? Family tree. He will say his father also had same neurological illness. He may write unknown neurological illness. Grandfather had unknown neurological illness and both died because of, some lung issues. Then answer is still Huntington's disease in a question. So pretty straightforward as a data. AD, PD, and Huntington's disease is what I have highlighted. The next statement is for those of you who are studying for like NEET PG. If he says the word, this is optional if you want to note down. This I would like you to read from psychiatry. If he says there is a dementia, but along with dementia, he says person is having visual hallucinations. Visual hallucinations would be like he is imagining animals in the room. He can say snake. He's not an alcoholic, right? Non-alcoholic patient. He can see animals in the room. He can see people in the room. Visual hallucinations are there along with dementia. Then it's not schizophrenia because dementia is also there. Then it becomes Lewy body dementia, LBD. So this is an additional point which if you want, you can note down, but then it has covered in the psychiatry component. But this is one slide which I've invested time into for comparison between the ADPD and the HD components. And now we talk about a peripheral nervous system disorder that is called as Guillain-Barré syndrome. For Guillain-Barré syndrome, the criteria are called as Brighton criteria because there is a demyelination that is happening. So there would be flaccid paralysis. Understandably, the paralysis will start from the feet, then we'll go up to the knee joint, then to the hip joint, then to the trunk, then to the arm. So it will go from bottom say upper. So the question will begin by saying this particular man, he has come to the hospital with inability to move his feet. Then the weakness will come in the knee joint of the patient, then the hip joint, then the trunk, then the arms. So paralysis क्योंकि नीचे से ऊपर जा रहा है, and the amount of paralysis in the left leg will be equal to the amount of paralysis in the right. Therefore, there would be FAME का F, that is flaccid paralysis, that is bilateral. He will mention areflexia and a lumbar puncture finding by the name of albuminocytological dissociation would be given in this patient. In albuminocytological dissociation, you will be given a report where everything will be normal. Where everything will be normal, the only thing deranged there will be the proteins that would be elevated, but this elevation takes minimum of at least 1 week to occur. So don't answer lumbar puncture as the investigational choice for this condition. It is nerve conduction velocity, because there is a demyelination of the nerves happening here of the peripheral nervous system. The disease has a monophasic course. Monophasic course means that this person might be having like paralysis developing so fast that within 12 hours, like the paralysis started first in the muscles around the ankle joint, knee joint, hip joint, then the trunk got involved, then the arms got involved, then the face of the patient got involved. So the paralysis is going from bottom upwards. Then you will say that this is a ascending symmetrical paralysis, and within 12 hours the patient's whole body gets paralyzed, including the seventh cranial nerve. In some cases, however, the paralysis may not progress over something like 12 hours. It may progress over 28 days. The point to be understood is over 4 weeks. Over 4 weeks the paralysis is progressing. It is like paralysis is progressing in this patient very fast. It is going over a duration of like 28 days. Like first week only leg paralysis, second week truncal paralysis, third week arm paralysis, then face paralysis is occurring in this patient. And therefore I need to do electrophysiological studies, that is nerve conduction velocity, which is the investigational choice for this condition. फेम को फिर से प्रैक्टिस करते हैं. Flaccid paralysis, areflexia, monophasic course, electrophysiological studies are useful for diagnosis. The question will begin initially by like this person had food poisoning. He had food at local dhaba, Campylobacter jejuni, or he had fever due to Zika virus, or he had like jaundice, hepatitis E, और उसके about couple of weeks के बाद में there is development of antibodies due to type 2 hypersensitivity. Therefore antibodies will be causing demyelination, and the main aspect is flaccid paralysis, the commonest cranial nerve involved in this condition. The most common cranial nerve involved in patients with Guillain-Barré syndrome is the seventh nerve, and it is not a unilateral paralysis, guys. It's a bilateral. It is not a unilateral. It is a bilateral paralysis that is occurring in this patient, that is in the form of facial diplegia. It's not a unilateral manifestation, guys. It's a bilateral seventh nerve palsy. Unilateral is called as Bell's palsy. This would be not Bell's palsy. It is a facial diplegia. The commonest cranial nerve involved in this patient is seventh. It's a facial diplegia that would be happening. And if he says what is the first test, what is the best test, don't answer lumbar puncture. They will, in the question, first option will be albuminocytological dissociation. Your answer would be given as nerve conduction velocity. This disease causes paralysis from top to bottom, but bladder and bowel are spared. There is no bladder involvement. I'll just write it and then put a line over it. Bladder and bowel involvement is not seen with respect to patients of GBS. So overall, I can say at least from the hygiene perspective, it has a good prognosis. Then he will test your knowledge with respect to the variants of it. The commonest variant of this is called as acute, is written as AIDP. The full form of AIDP will be, obviously A is acute inflammatory demyelinating polyneuropathy. This is like the commonest presentation that we get here, that it will have motor manifestations, sensory manifestations, and even autonomic manifestations. What I mean by autonomic is postural, like orthostatic hypotension or postural hypotension can also be described, because there would be damage to T1 to T4 fibers. No, T1 to T4 fibers provide sympathomimetic stimulation to the heart. So if I have demyelination T1 to T4, then sympathomimetic stimulation to the heart is gone. Heart operates on sympathomimetic, parasympathomimetic vagus. Agar sympathomimetic activity is gone, then parasympathomimetic will override. So even autonomic features can be present in the form of bradycardia and hypotension. So if you are having motor and sensory and autonomic manifestations, we call it AIDP. But sometimes in these patients, we may be having only motor manifestations. If only motor manifestations are present, then we will call it AMAN, that is acute motor axonal neuropathy. If we are having only motor manifestations in this patient, then we will call it AMAN, that is acute motor axonal neuropathy. If we would be having motor plus sensory, if we are having only motor plus sensory, then we will say acute motor. Sensory would mean like paresthesias. Like this patient is saying that I'm having tingling sensation in my extremities, or I am having difficulty in climbing of stairs because I cannot feel the stairs under my foot. You know, when you climb stairs, you should be able to feel the surface under your foot. If nerves are damaged, nerves have motor activity and sensory activity. So therefore, the person could be having difficulty in climbing stairs, not only due to motor weakness, but due to sensory involvement also. So we call it AMSAN, where motor and sensory involvement is is there. But if we are having motor and sensory and autonomic manifestations altogether, autonomic would mean that sensory output to the heart is damaged, so parasympathomimic activity will override, and therefore you would be having is a development of bradycardia with hypotension also present. Then after this, I'm writing erasing this word M plus S plus autonomic. That was just to explain to you. The data is very clear. This is the commonest variety. Motor feature, sensory nerves have motor and sensory feature plus autonomic function also. They help in controlling the heart rate. So they can be bradycardia due to damage to the sympathomimetic fibers. Then comes a variant which is called as Miller-Fisher syndrome. This is the rarest form of Guillain-Barré syndrome. The rarest form of GBS, which is called as Miller-Fisher syndrome. The word is Miller-Fisher syndrome, has a triad. This triad is to be remembered as OAA. OAA would stand for ophthalmoplegia. Don't mix it with Wernicke's encephalopathy. I'll speak about it towards the end. OAA is ophthalmoplegia, where the commonest nerve that is involved in this condition is the third nerve. Guys, if you're listening to me carefully, the cranial nerve that was involved in GBS overall was the seventh nerve. So for AIDP, Aman Amsan, if he says like what is the cranial nerve involved, answer seventh. But if he says the word Miller-Fisher, then answer is not seventh. Answer is third nerve palsy, that is ophthalmoplegia. That is why I'm going into it. Then is ataxia, and then can be development of areflexia. So OAA is a triad that we get for Miller-Fisher syndrome. It is one of the rarest varieties of GBS. And for all the varieties, like the diagnostic algorithm is the same. Whichever term he says, what is first test nerve conduction velocity, what do you do after this, lumbar puncture. In lumbar puncture report, everything will be normal. The only thing deranged will be proteins, and then commonest cranial nerve involved is the seventh, but not in Miller-Fisher syndrome. The drug of choice for this condition is intravenous immunoglobulins. We can use plasmapheresis also. In fact, the efficacy of both of them, when they did a comparison trial and they found that the efficacy of both of them is equal. The question then arises, like a lot of students say, sir, then why did you answer that IVIG is the drug of choice if efficacy is equal? Then I want to say that it is easy to give. Intravenous immunoglobulins, the treatment cost will be in lakhs, but at least it is easy to administer. For plasmapheresis, you need a donor. You need multiple plasma donors, plus you need an expensive setup. So plasmapheresis is like can be used in a patient, he says, but like it will require more expensive setup. So IVIG is to be used. And the cause of death in this patient, if he says, why do patients of Guillain-Barré syndrome die? Guys, then one of the primary reasons for death in this patient would be diaphragmatic paralysis. In the previous conditions that I had discussed before you, the cause of death was aspiration pneumonia. It is respiratory involvement. But in this case, in GBS, the bad news is person would require ventilatory failure. In fact, couple of years ago, this happened in Pune. Outbreak occurred due to chicken which was non-veg contaminated with Campylobacter jejuni. This was a cloud kitchen. It was operating out of all these sites like, Zomato, Swiggy. People ordered this tail chicken, they ate it, and they developed first diarrhea. They recovered from diarrhea, but after 2 weeks, they developed this paralysis starting in the feet, going up like this from the feet to the trunk, and then they required diaphragmatic requirement. They required ventilator requirement. Now, in government medical college, limited ventilators are there. So, when so many people came together and had diaphragmatic, paralysis, then ventilators were not available. So, you know what people did? They beat up the doctors. They said, you are not providing us with ventilator. Doctors don't purchase ventilator. No, it is the minister who's supposed to. And when the minister came for round, everybody was touching his feet. Can you imagine? Right? You and me don't exude power. Just because we remain quiet, people just tend to take it on the face value that they tend to misbehave, right? Like you and me don't say anything, no? So koi bhi kuch bhi bol ke chala jata hai, right? So what happens is minister, like he's like offering that, he comes with that car, with that siren, everything blaring. Everybody bows down to power, man. And like everybody tries to bully the weak person. So that is what is happening in this particular case. So it is GBS. And now I want to bring to your attention some important questions regarding what is the most common cranial nerve involved in multiple sclerosis. Multiple sclerosis is discussed towards the end of this video. It is optic nerve, which is the most common nerve, and therefore like optic neuritis will be there. Even neuromyelitis optica, it is the optic nerve, but along with that spinal cord gets involved. If it's an anterior cranial fossa trauma, then going through the nose, because cribriform plate will get fractured, then it is the olfactory nerve that would be involved. That is one of the shortest cranial nerves. Then middle cranial fracture fossa, like punch to the side of the head, kicks to the side of the head, petrous part of the temporal bone can get injured. Then it is the facial nerve. In leprosy, it is against the facial nerve. In raised SCP, false localizing sign, Wernicke's encephalopathy, in all of them by default, it is the sixth nerve. Even in Wernicke's encephalopathy, it is the abducens nerve that is involved. In Guillain-Barré syndrome, as I explained to you, it is facial nerve that is involved. In fact, facial nerve in the form of in the form of diplegia. Whenever you read the word facial diplegia, then I mean, this is seen with GBS and this is seen with sarcoidosis. In sarcoidosis, you have non-casing granulomas in the salivary gland. So the salivary gland is inflamed, it is pressing on the seventh nerve, therefore facial nerve involvement will occur. Miller-Fisher syndrome and Millard-Gubler, again, confusion can occur. So for Millard-Gubler, it is the sixth and the seventh nerve both that get involved. So instead of writing abducens and facial, I'm writing sixth and seventh. These are ipsilateral that are involved. And along with this ipsilateral sixth and seventh nerve palsy, there is a contralateral hemiplegia that would be occurring in this patient. So I'm just writing H for it, contralateral hemiplegia. For Miller-Fisher syndrome, as I explained to you, it is ophthalmoplegia, areflexion, ataxia. But for this ophthalmoplegia, in Miller-Fisher syndrome, which is one of the rarest forms of Guillain-Barré syndrome, it's gonna be the third cranial nerve that is involved. So in fact, instead of writing ophthalmoplegia, I can just write a number that will make it easier for you. It is third nerve palsy. Third nerve palsy today in our discussion has come. How many times? I'll just make you revise it. Third nerve palsy has been discussed for PCOM, that is involving I drew most common location as ACOM, most prone to rupture PCOM, and I mentioned the third nerve palsy. I drew in yellow the nerve as adjacent to the PCOM. Then diabetes mellitus, that is like again a point to be remembered. Most common cranial nerve involved in diabetes is third nerve. Midbrain syndromes, I described 3 of them. It was Weber syndrome. वीबर के बाद में मैंने बताया था नॉन थैंगल. रिमेंबर नॉन थैंगल में इट वाज नॉट स्टेबल पेशेंट, सुपीरियर सेरिबेलर peduncle was getting involved. Then I mentioned Benedict syndrome. Remember Benedict में basal ganglia was involved. So all of them were having ultimately a third nerve palsy. So you have added like third nerve palsy. इनमें सबसे ज़्यादा repeat हो रही है. Third nerve palsy is present with Becomberry, diabetes, midbrain के 3 versions, and then with Miller-Fisher syndrome. But sixth nerve palsy is what you read with respect to raised ICP, false localizing sign. We call it false localizing क्योंकि देखो disease is not in the sixth nerve. It is that sixth nerve is going through that area where the pressure in the brain is more. So this is a very high yield slide, guys, for the most common cranial nerve involvement that you need to remember. And now we will take care of something that you would have read in multiple other subjects, neurocutaneous disorders. One of them is tuberous sclerosis. The pattern of inheritance is autosomal dominant. So the question will begin by saying father is an epileptic and daughter is also epileptic. The genes involved are TSC1 and TST2 on 9 and 16 respectively, and usually they will be mentioning cutaneous manifestations. The cutaneous manifestations in the patient would be in the distribution like this particular butterfly distribution, but I'm not saying a butterfly rash. I'm saying these would be acneiform lesions. These are acneiform lesions in a butterfly distribution. That is what the examiner will say, and you will say that these acneiform lesions in butterfly distribution is adenoma sebaceum. However, this manifestation will occur at the age of puberty. These acneiform lesions in butterfly distribution in this condition will develop at the age of puberty. So what will be the manifestation seen earlier? Then I had shown you an image of ash leaf macules. I had shown an image of a trunk of a child right in beginning in neurology. That is, ash leaf macules are present right at birth, and acneiform lesions in butterfly distribution develop at the age of puberty. On the skin of this patient, you might get lesions which will be having a orange peel consistency. That orange peel consistency, one you read with respect to the Tude orange. Second is for Sjagren's patch. So when you combine these cutaneous manifestations with a lesion in the brain, which is the reason why these patients will be having seizures. These lesion in the brain, they look like potatoes in the brain. That is why the name is not tuberous sclerosis. Tuber means a potato. So these are called as subependymal astrocytoma. They might be written as subependymal nodules, or they might be written as subependymal astrocytoma. This is the reason why this person is having epilepsy, and this is like present since a very young age. In first year of life, the lesion present there is called as the CNS lesion is infantile spasm, and later focal seizures could be developing in these patients. Let's revise the manifestations here. Ash leaf is a mnemonic. Ash leaf is a hypomelanotic macules as I shown to you in the image. Initially, first year of life, you have infantile spasm, later focal years. Then these patients can be having hamartomas in the retina, lung lesions present. You have to remember these names. That is what the examiner wants to hear. Lymphangioliomyomatosis. Then the E manifestation is for the involvement of the brain, that is subependymal astrocytomas that can cause encephalopathy. We use a drug for it, that is everolimus, that is mTOR inhibitors to reduce the growth and control the epilepsy. Then angiofibromas or adenoma sebaceum is like the skin manifestation again, and the facial plaque or the Sjagren's patch is present. So this is just a mnemonic to help you remember, but the minimum I expect you to remember is what I gave in the diagrammatic representation superiorly. Angiofibromas, that is like adenoma sebaceum slash, that's alternative terminology, Sjagren's pan and Ashleigh macules with subependymal astrocytomas complete the tuberous sclerosis complex, and this happens to be a neurocutaneous disorder. Then comes Sturge-Weber syndrome, where the mnemonic is Sturge. There would be seizures. The reason why these seizures are occurring is because in the brain of this person, you can notice that there is a triumph tract calcification present. There is a cavernous angioma in the brain. These patients will be having a port wine stain. The facial presentation will be a port wine stain, and in the brain there is on the same side a presentation of a cavernous angioma, which will explain like why these patients would be having development of seizures. I'll write the lesion also. The reason for seizures in this patient is that in the brain there is a malformation called as cavernous angioma, which would be on the same side on which the port wine stain would be present. So seizures are there. S is seizures due to cavernous angioma, which is acting like a epileptogenic focus. In the trigeminal nerve distribution on the face, there is a port wine stain. There is the unilateral weakness because this could affect the corticospinal pathway, and therefore the weakness will obviously be occurring on the opposite side of wherever the lesion is present, like cavernous angioma on the left, the weakness would come on the right. Then since the patient is having seizures since birth, there would be mental retardation. G is for the glaucoma component, and the I is the buphthalmos, which is again related to glaucoma. And G also helps you remember a mutation here, that is GNAQ1 mutation. Unlike TSC1 and TSC2, which are easier 9 and 16, here it is GNAQ1 somatic mutation, which helps in identification. Then comes the all favorite neurofibromatosis 1. The standard MCQ on this will mainly revolve around optic glioma, but other features can be like cafeolate macules. You need at least 6 of them. The size of them will vary pre and post-pubertal. Pre-pubertal more than 5, post-pubertal more than 15, and multiple macules should be present with axillary freckling. Then there should be like demonstration by genetic studies of defect on chromosome number 17. Eye involvement is again hamartomas, and that these are hamartomas on the iris of the patient. I mean, I'll write the word iris hamartomas, which are called as Lisch nodules. This is again very classical question that they'll give you an image of a close-up. You can see this is a potato man. Potato man is that small tumors in the skin which are originating from the nerve fibers which are innervating the skin. The term we use for it is potato tumor, or we say the word von Recklinghausen disease. A peculiar presentation of this condition is that if you keep your finger on the eye of the patient, you can feel the pulsation of the internal carotid artery. In you and me, the pulsation of the internal carotid artery cannot be felt because sphenoid bone is there, but these patients have a sphenoid bone dysplasia. That is why in these patients you could be having they could be pulsating proptosis, or pulsations can be felt when you keep your finger over the eyeball of the patient. He may not say the word pulsations palpated, he might say the word sphenoid bone, sphenoid wing dysplasia, and the tumor risk is increased, that is pheochromocytoma. When I was describing pheo, I emphasized this. In fact, the two most important informations for neurofibromatosis from the cafe spot mnemonic is O and T, optic glioma and neurofibromatosis 1 association. Next up is von Hippel-Lindau syndrome. The mnemonic to remember this is 3VHL clear. By clear, I mean 1 is the association with clear cell carcinoma of the kidney, right? RCC. From the VHL perspective, the V's to be remembered is vascular tumors of the CNS and the retina. You see, in the cerebellum, we have so many cells like Purkinje cell, granular cell, basket cell, Golgi cell. None of them are producing a tumor. It is the blood vessels of the retina that are getting involved here. So cerebellar and retinal hemangioblastoma is one of the reasons that it is asked. Plus it is associated with pheochromocytoma and endolymphatic tumors. So yeah, these points H and L are also to be remembered. But the must know fact for you guys is rather the cerebellar and the, one liner question, cerebellar and retinal hemangioblastomas are associated with von Hippel-Lindau. Next is ataxia, telangiectasia. 2 points can be picked up right away. Ataxia is the neurological, telangiectasia is the skin manifestation here. The highlight of this condition is that you get cerebellar ataxia, understandably telangiectasia, neuro and cutaneous are done. But why is he asking this is mainly because this condition would be having absence of antibodies like immunoglobulin A and E. So repeated infections are present in this condition. Here what he wants to hear is repeated infections and increased tendency for development of blood cancer. Ataxia telangiectasia, he doesn't want to hear the CNS manifestation. Ataxia is there, it's written in the question. Telangiectasia is the cutaneous manifestation. वो क्या सुनना चाहता है? One is the increased incidence of repeated infections in this patient due to deficiency of immunoglobulin A and E, and second is the increased risk of blood cancer, which he will not write as blood cancer, लिखा होगा increased risk of lymphoreticular malignancies for ataxia telangiectasia. The chromosome involved here is chromosome 11 and there is the ATM mutation. So next up is a quick revision of the neurocutaneous disorders. For neurofibromatosis 1, where I described potatoes on the skin of the patient, we'll call it von Recklinghausen disorder. The highlight of this condition would be Lisch nodules. Those are like iris hamartomas. The association is with NF1 gene on chromosome number 17, and this is an autosomal dominant condition with association with even pheochromocytoma, as explained to you already. Then is neurofibromatosis 2. This is famous because of association with vestibular schwannomas. In contrast, like I had already explained to you that in neurofibromatosis 1, there's one more tumor that is associated, that is by the name of optic glioma. The gene here is neurofibromatosis 2 is NF2, obviously, and chromosome is also beginning with 2, that is 22. For tuberous sclerosis, I've already provided multiple inputs, so I'll do 2 additional points. The additional points are like routine information was subependymal nodules or astrocytomas, that was potatoes in the brain, Ashley macule, Chagrin's patch. But now mentioning a cardiac manifestation of this condition, that is a rhabdomyoma. Mark my words there, not a rhabdomyxoma, but a rhabdomyoma. Similarly, he can also ask you regarding the kidney lesion, which is seen here, and this is very, very peculiar. You will never read this name anywhere else. I mean, normally you read about like angioma, you read about myomas, you read about lipomas, but here all the 3 tissues are present together, and in the kidney, these 3 lesions are present. So he will say, what is the kidney association of tuberous sclerosis complex? Your answer is angiomyolipoma, and the genes involved are TSC1 and TSC2 gene coding for 2 proteins, hamartin and tuberin, on chromosome 9 and 16 respectively. For Sturge-Weber syndrome, I had told you regarding the word cavernous angioma. But at the moment, I'm just slightly changing the vocabulary to say sometimes written as leptomeningeal angioma, and the triumphal calcification remains uniform. It will act like epileptogenic focus. There can be glaucoma occurring in this patient. The gene involved is GNAQ1 gene. Then for von Hippel-Lindau, repetition of the fact that it is associated with pheochromocytoma and retinal and cerebellar hemangioblastomas. Obviously, association with renal cell cancer would be present. And for ataxia telangiectasia, 2 data are pretty straightforward. Cerebellar ataxia telangiectasia in the conjunctiva or on the face, and these are dilated blood vessels. And then is increased incidence of lymphoreticular malignancies and increased incidence of infections also. Peculiar name ATM, ATM gene here on chromosome number 11. So a lot of fact-based information with respect to neurocutaneous disorders. But next that I'll describe will be having a lot of logic, and I'll be describing to you a topic by the name of multiple sclerosis. Now, this is characterized by demyelination occurring in the brain, in the central nervous system. Prior to this, I had explained to you demyelination of the peripheral nervous system that was valid for Guillain-Barré syndrome. So, if you look at the MRI head of this patient, you can see these finger-like projections. These are areas of demyelination in the brain where the repair system oligodendrocytes have already started working. So, the technical term that I'm using at the moment is Dawson fingers, and these Dawson fingers are also called as plaques. Now, suppose like these plaques are going to be like finger-like projections. What I can say is that if they give you a MRI in which you can see these round potato-like lesions, that is subependymal astrocytomas in tuberous sclerosis. But here it is not round lesions, it is like those finger-like projections. They're also called as plaques, and the clinical manifestations of multiple sclerosis will depend upon where the plaques are located. Like I'll say this verbally, then I'll highlight on the slide. Like the plaques could be present in the cerebellum. So person could be having intentional tremors. Person could be having manifestations of cerebellar damage like a gait ataxia. If the plaques will be occurring in the frontal lobe of the brain, frontal lobe helps in control of the urinary bladder. So person might be having like urinary incontinence, antisocial behavior that might start coming up in a person. So the location of the plaques will decide what will be the clinical manifestation of this patient. Like most of the time, because this is an autoimmune disorder, so this is the young lady. Complaints of her is that she had passed, adult lady, 25 years years of age. She says, doctor, I'm very embarrassed, but I passed urine in the bed 2 to 3 times in last 1 week. She says, I don't understand. I mean, little children, 5, 6 year old children pass urine in the bed. She says, sir, I'm very embarrassed to tell you that she passed urine in the bed. And she's also telling you that I get a lot of cramps. She's physically very active. So she goes in the gym. She says, my trainer tells me that I'm very injury prone because I get cramps. Now, when you examined her, it's not actually a cramp. She's having a spasm. She's having spasticity of her hamstring muscle. And that spasticity is being perceived by her as a spasm because the muscles are very tight. Maybe her coach or physiotherapist were doing massage over the muscle. So he said, your muscles are so tight. No, that's because of the spasm. But it's not some exercise induced cramp that is happening. What she's calling as an exercise induced cramp is actually spasticity, because even the plaques can be developing in the corticospinal pathway. So I'll repeat the profile. I'll write it down subsequently. Young female. She comes with complaints of urinary incontinence multiple times in last 1 month. She also says that she's very injury prone. You identified her to be having spasticity of her leg, and she was also having a Babinski sign present. Very shocking. 25 years of age, there is a Babinski sign present. Corticospinal pathway is getting involved, and then cerebellum can get involved. You could get ataxia. You could get intentional tremors in a patient. So depending on the location of the plaques, multiple varied manifestations will be seen in this disorder, which is caused by autoreactive T lymphocytes, which cause development of demyelination. Prior to this, I discussed demyelination in Guillain-Barré syndrome. That will affect the peripheral nervous system. It will affect the peripheral nerves and nerve roots which are coming out of the spinal cord. But in multiple sclerosis, the damage is predominantly in the brain, sometimes even in the spinal cord, but not in the nerve roots that are coming out. If the nerve roots that are coming out of the spinal cord get involved, or if it's the peripheral nerves getting involved, that's GPS. This is limited primarily to the brain and sometimes in the spinal cord. So he will ask you, what is the target? Your target will be two, MOG and MBP. What does MBP stand for? Myelin basic protein. I don't need to write the full form. MBP is myelin basic protein. What is MOG? Is myelin oligodendrocyte glycoprotein. This is what people make a lot of mistake with. So your answer will be that the autoreactive T lymphocytes are attacking against what antigens? That is the covering of the axons. That is MBP and the MOG. The myelin basic protein and the myelin oligodendrocytes are getting affected. Now, because of the damage, the repair system of the brain, see, in the brain we have, like in the liver, we have repair system, no stellate cells that cause fibrosis. The repair system of the brain is called as oligodendrocytes. So they will come into action, and this results in formation of plaques at multiple sites. The common sites are periventricular. Optic nerve gets involved, so this lady will start having blurring of vision. She's saying like, doctor, I think I need change of glasses. Maybe she did not come to me. She went to some optometrist. Like, a lot of people, if they have vision issues, they might think they might need glasses. So she's going to optometrist. Her glass number is changing. Vision is not improving. When she came to me, she said, I can't even check out the color of my dress. No, it's all looking black and white to me. Even the color vision is lost. Most of the time, multiple sclerosis causes a unilateral optic neuritis. And one of the earlier slides I had told you, the most common cranial nerve involved in multiple sclerosis patients is optic nerve. So optic neuritis is the manifestation. Brainstem involvement can cause like cranial nerve palsies, and spinal cord involvement can also happen. Then is an MCQ in the app, shadow plaques. Like I described the word plaque, there is a shadow plaque. Shadow plaque, he is asked, what do you mean by the word shadow plaque? Your answer will be the body is trying to cause further improvement. Like the body had demyelination, now body is trying to repair the damage by development of remyelination. Then there are a couple of environmental risk factors. Like this disorder is very unlikely or less likely in Indian population. This will be mostly like patients who are coming to us on medical tourism, or like this patient has just come to visit India. Like she's an American patient, she's a Canadian patient, she's a European patient, like maybe Irish, maybe British, maybe Finnish, Scandinavian countries. So this disease is more common in those countries where sunlight is scanty, environmental deficiency due to environmental lack of sunlight, vitamin D deficiency is prevalent in these populations, and this is like an environmental risk factor. Obviously, smoking is a risk factor, HHV4 exposure is a risk factor, but I wanted to highlight regarding an environmental risk factor, that is lack of sunlight exposure, adequate sunlight exposure, because these countries know sometimes wo 6 mahine for 6 months it's like dark there. So North America, Europe is gonna be the usual descent of these patients. Obviously, can be an Indian patient also, but is more common in Western origin patients. Then would be a very interesting question. What is the most common manifestation of this patient? In ESET, people love to ask about it. The most common involvement is not optic neuritis. The most common cranial nerve involved in this condition, agreed, optic nerve. But the most common manifestation is sensory disturbances, which would be like paresthesia, tingling, rotting flesh sensation, varied descriptions by various patients, but it will be initially like peripheral. Any doctor initially will start giving vitamin B12 supplements to this patient, thinking that, oh, like in India, a lot of people are vegetarian. So the physician started giving B12 supplements to this lady, thinking she's having peripheral neuritis manifestations. Then comes a very interesting feature that will be given, Lehermite sign. Lehermite sign was first time described as a manifestation of neurosyphilis that is called as Taves dorsalis. Now we don't have like neurosyphilis so common or Taves dorsalis. So this manifestation, which was earlier described in Taves dorsalis, is described here also. What is Lehermite sign? You ask the patient to flex the neck. I'm not talking about nuchal rigidity now. You ask the patient to flex the neck like this. It will cause a shooting pain in the back of the patient going into the legs. Something identical to what you get in sciatica. Sciatica will be having low backache, and low backache will be radiating to the back of the thigh. Here I'm not saying low backache radiating to the thigh. I'm saying flexion of the neck is causing pain to radiate down the back and then into probably the legs of the patient. And anyway, you get an optic neuritis, which most of the time would be unilateral and may be associated with pain. When I describe neuromyelitis optica to you, then neuromyelitis optica usually has a bilateral optic neuritis, but this disease has plaque formation. Why there is an optic neuritis is because, let me say, this is the optic nerve. There is formation of multiple plaques. There is demyelination, body is trying to cause remyelination, so shadow plaques also. So when the light, is to travel through this, electrical impulses, light will hit the retina, then electrical impulses are supposed to travel through the optic nerve. So all I'm trying to do in a symbolic diagram is that optic nerve is having multiple plaques present. That also, like I decided to draw it to say that one of the tests that sometimes can be written during the workup of this patient is called as VEP, that is called as visual evoked potential, because if I want to check whether the optic nerve is functioning optimally or not, then VEP test would be done. Obviously, I'll do an MRI of this patient, a contrast-based MRI, but like a lot of time the plaques may be very small and they may not be visible on an MRI. So visual evoked potential is a test that can be done in these patients to demonstrate the presence of optic nerve plaques indirectly, because then the voltage or the current that would be traveling through the optic nerve of the patient will be suboptimal. The complaints of this lady is her visual acuity is decreasing. The complaints of this lady is that her color vision is decreasing. So question will be descriptive. From one eye, she went to optometrist. She said, I cannot see properly. He said, I think you need glasses. So he gave her a set of glasses. She says, she used it for a while. She says no improvement. So 2-3 times she went to some private optometrist shop, and her vision did not improve. That is when she decided to come to our clinic. And when we started talking to her, we realized that this is not a refraction error. You see, normally if somebody is having blurring of vision from one eye, then a non-medical person will not come to a doctor like you and me. They'll start go to an optometrist. Chashme ka zarurat hai. So the question will be descriptive, like she made her prescription glasses made, the vision is not improving. And today when she came, she said, I have pain in the eye, I'm having visual blurring. That will be the usual description. There are two things I said. One is the predominant visual blurring that can be present in this case, unilateral, and the second can be that there can be a decrease in the color vision of the patient apart from the eye pain that she is also complaining of. Then I'll say like this, our both eyes can, if I look at my eyes, I can move both my eyes towards my right like this. I can move both my eyes to left like this. I'm looking in center, but both my eyes can go to right, both my eyes can go towards left, because we have is a conjugate gaze. You see, the sixth nerve nucleus of one side is connected to the third nerve nucleus of the opposite side. There is an anatomical area in our brain which connects the sixth nerve nucleus of one with the third nerve nucleus of the other side. So suppose I'm looking to my right, then this side my lateral rectus is being used, this side my medial rectus is being used. The coordination between the two is through an area called as MLF. We call it medial longitudinal fasciculus. And what happens in this condition is that there would be a plaque developing in the medial longitudinal fasciculus, because of which now this conjugate gaze will not be possible. Like in you and me, we can move both our eyes towards the right, both our our eyes towards left. These patients will not be able to do this. So the term used for is called as internuclear, because nucleus of the sixth and the nucleus of the third is connected via the medial longitudinal fasciculus. Now this is not working properly because the autoreactive T lymphocytes are causing damage here. The oligodendrocytes are coming to repair the damage, and as a result of this, because medial longitudinal fasciculus is damaged, so the word is internuclear ophthalmoplegia, that is conjugate gaze palsy, could be developing. Then is a very peculiar manifestation. Remember, I told you when she was saying that I am going to gym and like I'm getting these cramps. What is happening in this patient is that increase of body temperature will trigger neurological findings. When I say like this, most of the time students are like, what sir, what did you say? Increase of body temperature is causing heat intolerance. No, man, I'm not describing thyrotoxicosis. I'm not describing Graves' disease to you. I am describing multiple sclerosis. This phenomenon was first time described in Russian females by a Russian doctor. We call it Utov phenomenon. Utov phenomenon means that if these patients will do exercise, or this patient will go and work out in a gym, or for that matter of fact, if this patient will take a hot shower, then neurological symptoms in this patient will tend to worsen. This is a very peculiar statement that I'm making, is that there is development of neurological symptoms and worsening of neurological symptoms on increase of body temperature. We don't read this word anywhere else in medical literature. So this is one of the characteristic manifestations that is seen in this particular condition. Examiner in the exam will not directly say the word Utov phenomenon, but he will say that whenever this lady takes a hot shower bath, something like a hot shower bath, sauna, steam, like in Western countries, this is very common. They go for steam bath, sauna bath, workout in a gym. Then like the neurological symptoms, like the blurring of vision is getting worsened. The spasticity of the muscles or the cramp in the what she's calling as a cramp in the hamstring is actually spasticity that will worsen. The episodes of urinary incontinence in this patient will worsen. And when you will examine this patient, you will notice that there would be upper motor neuron signs. Upper motor neuron signs would be like spasticity, Babinski sign. They're so such common things that I don't need to write the word Babinski sign. You can even know that is dorsiflexion of the great toe and fanning of the smaller toes. And then as I explained, sometimes the person is saying to you that I was sleeping in middle of night. Suddenly I found that I was lying in my own urine. And the patient is feeling very embarrassed. First time patient will thought that maybe it just happened by chance. Maybe like the patient had consumed some beer at night, or maybe too much of drinks or tea and coffee, bladder was full. So maybe, I passed urine in the bed accidentally. But then it has happened a couple of times and they're realizing that there could be some medical reason. And yes, there is a medical reason, which is that in these patients, there is plaque formation in the paracentral lobule of the brain. Paracentral lobule is what I drawn earlier when I was describing stroke. It controls the bladder, so urinary incontinence can occur. Now we will talk about revised McDonald's criteria, which are useful for diagnosis of this condition. In revised McDonald's criteria, he focuses on a couple of investigations. The main investigation or the imaging modality of choice for this particular condition is a gadolinium enhanced MRI. The last time I mentioned the word gadolinium enhanced MRI as an investigation of choice for neurocysticercosis. Remember, we were discussing about that ring enhancing lesions and starry sky appearance. Remember that it is not that starry sky, which starry sky can be seen on plain MRI also. It is the ring enhancing lesion, the vasogenic cerebral edema, that was demonstrable. This time it is going to be dozen fingers, and then there will be certain very peculiar investigations written in this question which will make the answer super easy. Like he will say CSF electrophoresis was being done. Last time I spoke about electrophoresis was serum and urinary electrophoresis for M spike and multiple myeloma. In hematology I've spoken about. Or electrophoresis is like HPLC, high performance liquid chromatography for identification of thalassemia. So routinely you will hear me talking about electrophoresis in hematology section, like urinary protein electrophoresis, serum protein electrophoresis showing a M spike, or like hemoglobin electrophoresis for thalassemia. But today I'm talking about CSF electrophoresis showing oligoclonal bands. This we don't read routinely. And then he may say visual evoked potential of this patient was done, and it shows an increased latency. Like what he means by the word increased latency is that the current is not able to travel through the optic nerve because of these small plaques which may not be visible on MRI. For the acute episodes of, like, it can be two-step question. He will himself give you this clinical profile describing a young lady from North America having neurological symptoms developing and worsening on heat exposure, and he will himself tell you there is Dawson finger seen, visual evoked potential shows increased latency in one of her optic nerves. She is literally going blind in one eye, and he will say, what is the first line management? Your answer would be given as steroids, that is methylprednisolone. But then we evaluate the severity of the disease. So the severity is assessed by Kutzke expanded disability score. What I mean by Kutzke expanded disability score, or EDSS, would be like, for example, I can say like this patient is become totally bedridden. Then I can say, like, at least in a bedridden patient, they can drink with help of a straw. At least they can drink water with help of a straw. At least they can eat food by themselves, because at least the brainstem is not involved. But suppose patient is bedridden and brainstem is also involved, and patient cannot even drink water from a straw and cannot even swallow food, then aspiration pneumonia will increase. So what I want to say is that quality of life will decrease. This particular medical disorder usually causes morbidity and decreases the quality of life to the level that in the later stages, if treatment is not given, even the brainstem gets involved by plaques, and therefore like gag reflex, cough reflex in the patient can be affected. So we also need to give to these patients disease modifying drugs. Now, these disease modifying drugs are the ones which you have to read up from pharmacology, though I'm introducing the most important one here. The disease modifying drug with respect to multiple sclerosis that is usually asked is ocrelizumab. Ocrelizumab is like that one monoclonal antibody that has been proved to be magical for management of these patients. Otherwise, like earlier, the quality of life of these patients was bad. We also have oral molecules like fingolimod. We have glatiramer. In fact, glatiramer is again a very interesting drug. Glatiramer is a drug that acts like a decoy antigen. Glatiramer is one whose chemical structure, I mean, we have developed glatiramer as a drug whose chemical structure is same as that of myelin basic protein. So the autoreactive T lymphocytes will start thinking that this is myelin basic protein over the in the brain, and they will start attacking the molecule of glatiramer. So I said, therefore, like glatiramer is like a decoy antigen. Like, I'll give another example, like in Operation Sindoor, whenever Rafales went before, in front of our Rafales, there were a couple of drones flying, and these drones that were flying, they were having the heat signature of Rafale and Su-30. So the Pakis thought that we were like sending in Rafales, which are like the lead Rafales. So they thought that when they fired those missiles, and they were claiming that they had downed our Rafales, those were the decoys that they had shot down. I mean, this is all documented subsequently, and we did not make any claims at that point of time. But if you look at our Vayu Sena exercises subsequently, all the tail numbers that they had said were shot down by the Pakis. All the tail numbers are still visible. Now they're saying you repainted them, right? I mean, it doesn't happen like that in the forces. But anyway, coming back to the agenda, decoy antigen, I'll give the example once again. Like, we flew a drone that was having the same heat signature, wingspan signature, exhaust signature, exactly replicating that of a Rafale. So the SAM battery of Pakistanis thought that this is the Rafale that they're looking for. The actual Rafale was behind it, right? And that second Rafale, the moment the decoy went off, this one was able to fire its scalp and hammer missiles. And then, we were able to take up a couple of targets. I'm not a warmonger, but I definitely want to talk about technology. So here we are talking about technology again. We are wasting the effect of the immune system, because glatiramer is acting like a decoy antigen. So the antibody will get wasted here, and then we can use interferon beta for management of these patients as well. This was earlier the drug of choice, but now it is like ocrelizumab, natalizumab. They have very good results that we can be seeing. With natalizumab, however, I would like to mention a side effect that is like it can actually contribute to a side effect by the name of progressive multifocal leukoencephalopathy. He will say which virus causes this, because when immunity will decrease, then there can be a virus that can be actually causing a damage. So natalizumab is only given in JC virus negative patients, and otherwise, like if the person is even if you don't get into the technicals of JC virus negative patient, what I want to say is that JC virus, John Cunningham virus, they named the virus after the patient in whom it was identified, that causes progressive multifocal leukoencephalopathy. So that's like one of the rare side effects of this drug that can be asked. And as far as the progression of this disease is concerned, one manifestation can be like this, that one symptom like occurred of urinary incontinence. Then the new symptom, first one did not improve, urinary incontinence is continuing, and the second symptom of spasticity appeared. Then the third symptom of vision deficit in the patient occurred. Then paresthesias also started occurring. Then gait ataxia also started occurring. So one after the other neurological symptoms, like this is January, this is February, this is March, this is April. So one after the other symptoms are coming in the patient, one after the other, and the first one is not improving. So we will call it primary progressive multiple sclerosis. But let me change the perspective. Suppose I say to you that patient in month of January had incontinence for 2 days, then it disappeared. The month of February, no symptoms. In the month of March, person had development of spasticity, which persisted almost for a week. I had to give baclofen, then the spasticity went down because all autoimmune disorders have a waxing and a waning course. Then in the month of April, this patient started having visual problems, which persisted for almost like 7 days and then went away. So in January, symptom came. February, no symptoms were present. March, a new symptom came. Previous one had went away. In like may say April, the visual blurring was coming up. So this is what is called as relapsing remitting multiple sclerosis. This is the most common subtype of multiple sclerosis, that symptoms keep on coming and going. The first symptom that had appeared, this will persist for a few days, disappear, then a new symptom will appear in a patient, but in some symptoms don't improve. So primary progressive, and if I combine the two, then it becomes secondary progressive multiple sclerosis. Secondary progressive multiple sclerosis would be like, let me say in 2026, let me say, patient was having RRMS. In 2027, there is a PPMS occurring in a patient. So if I'm having a combination of the two, it becomes a secondary progressive multiple sclerosis. So these are the three subtypes among which he will say what is the most common subtype seen, which is having the worst prognosis. So like a PPMS has a worst prognosis, and in INISET he had asked like what drug can be used for this. That is going to be ocrelizumab. Then there's a variant by the name of Marburg. I said normally this disease does not cause mortality, it causes morbidity, but there is a Marburg variant of multiple sclerosis which can cause death in 2 years due to a fulminant cause. This is again a question from the INISET perspective. I can give a parallel here. Parallel is like in Guillain-Barré syndrome, I was describing that rare variant. No, that was Miller-Fisher syndrome. Similarly, here a rare variant of multiple sclerosis is called as Marburg variant. Now I will describe to you a disease that was formerly called as Devick's disease. Here two things will be occurring together. The name is neuromyelitis optica. So one, you will be having in this condition a young female with bilateral optic neuritis, and bilateral vision is getting affected. Usually it's going to be painless, not painful here. And along with this, there would be transverse myelitis. Transverse myelitis means inflammation of the spinal cord, and because of this, there would be like paralysis occurring in the legs of the patient also. So in multiple sclerosis, I was not describing any paralysis of the legs, or like here I can also, apart from the paralysis or weakness in the legs because of which the person can fall. You know, transverse myelitis is a condition in which there is the inflammation of the spinal cord. So there would be weakness in the limbs due to which falls can be experienced in this patient. And transverse myelitis can even cause a bladder and a bowel involvement, that is in the form of incontinence, that would be seen. In Guillain-Barré syndrome, bladder and bowel are spared. In Guillain-Barré syndrome, we have paralysis of legs, that is okay. But in Guillain-Barré syndrome, if you recall, we did not have optic neuritis. Now, in Guillain-Barré syndrome, it was seventh nerve getting involved and bladder and bowel was not involved there. So what I wanted to bring to your attention is that he will not write the word transverse myelitis. He will say patient is having weakness in limbs. So you as a doctor will be thinking, oh, there's a power loss in the legs of the patient, so it can be GBS. See, in Guillain-Barré syndrome, if he says bilateral seventh nerve paralysis, facial diplegia, I'm okay with it. He says bladder are not involved in GBS, I'm okay with it. But if he says weakness in limbs with bladder and bowel involvement and bilateral optic neuritis, then please do not answer Guillain-Barré syndrome. This is one of the common errors the student make, that because question will begin with weakness, they start thinking in terms of GBS. Agreed, your thought process is fine, but then GBS does not have an optic neuritis, that too bilaterally. We don't have a bladder and a bowel involvement. Your answer is Devick's disease. Now the name is neuromyelitis optica. In this condition, the main hint in the question would be if he will himself mention the name of this antibody, anti-aquaporin 4 antibody, then this will become super easy for you. But like even if like this term anti-aquaporin 4 antibody is not given, you should be able to crack the question on the inputs that are provided to you. Then additional information that can be given in this question is in the form of A, B, C, D, E. So let me also describe area postrema syndrome. Area postrema means that this area for this disease, the antibodies can affect the vomiting center, so intractable vomiting and hiccups can be present. Then there can be brainstem syndrome. So brainstem syndrome would mean that there would always be contralateral hemiplegia, as I explained to you. Obviously, in brain involvement, there's a contralateral hemiplegia, but there would always be an ipsilateral cranial palsy. Like if in this condition the antibody is attacking the midbrain, then third nerve palsy will be there. If it is affecting the pons, then the sixth and the seventh nerve would be involved. If it will be involving the lateral part of the medulla, then 5, 8, 9, 10. Remember lateral medullary syndrome, 5, 8, 9, 10 can be involved. If it is the medial part of the brainstem, medial part of the medulla getting involved, 12th nerve will get involved. So I've not written any number here, but I just wanted to remind you that don't be surprised that apart from these manifestations of bilateral optic neuritis, bladder bubble involvement in this condition, the question might mention regarding hiccups, vomiting, crossed stroke like manifestations, but he will have to then mention that the MRI of this patient of the spine shows evidence of demyelination. How will he write that MRI spine finding? He will write the word LETM, longitudinally extensive transverse myelitis. I wrote the broad term na TM. The MCQ will say the word LETM, longitudinally extensive transverse myelitis. That means more than 3 vertebral segments are involved. As I said, bladder involvement is present here. Then a lot of these patients will be having because hypothalamus is getting involved. So hypothalamus controls appetite. Hypothalamus also regulates sleep. So you will also read in these questions unexplained weight loss, hypersomnolence, which is called as diencephalic syndrome. So let's revise the ABCD here. Area postrema, brainstem, cord. Then cord involvement is the transverse myelitis, LETM part. Diencephalic is unexplained weight loss, and eye involvement can be, as I explained, optic neuritis bilateral. The highlight is these two features are the must-have things which should be present here. Additional is just noise. You know why we say cut the noise is because they will increase the length of the question. Like an FMG exam, like they made 4 5 liner questions. I mean, students were crying after the paper, man, sir. Reading the question itself is taking 2 minutes. I agree, but if you pick up these words, the presence of bilateral optic neuritis, longitudinal extensive transverse myelitis, you need to filter of the noise. करने दो बकवास उसको, doesn't matter. It's like हर बार बोलता ना चिप्स का लेस का पैकेट हवा भर रखी है उसमें, just to upset your mind. नहीं होना upset यार. I mean, patient भी आएगा तो they'll say a lot of things. Now we need to filter what patient will do, blah blah blah, right? Though it's wrong for me to say like that. No, patient is suffering, so he will say. But what I'm saying is that to the doctor, if he's saying so much, you need to understand what is the relevant part. Don't tell the patient shut up. Let the patient talk. Obviously, you have to give freedom to the patient to let him talk. More the patient will talk, more the things that you will understand from the disease process, but you have to filter out the data from the clinical domain. No, so maybe my wordings were a little wrong, but then at the same time, I say that my intent is not wrong. I obviously want the best for our patients. So neuromyelitis optica, Devick's disease is the topic that we're discussing, and here the question will mention anti-copperin 4 antibody positivity, MRI spine showing longitudinally extensive transverse myelitis. We give IV steroids with plasma exchange, and for maintenance here the monoclonal antibody to be used is rituximab. Coming to the next aspect, Stephen Hawking, the scientist, had this motor neuron disease. The image of tongue fasciculations here is that unmistakable thing. I mean, if they ever give you tongue fasciculations, no, then the first thing you need to understand is that the person is having involvement of the hypoglossal nerve nucleus, and that nucleus, if it's affected, lower motor neuron manifestation or tongue fasciculations will occur. Motor neuron disease occurs due to superoxide dismutase 1 mutation, and because of this superoxide dismutase 1 mutation, free radical damage is occurring in the brain as well as in the spinal cord, along with glutamate excitotoxicity. So two things I said. One is glutamate excitotoxicity. Second is the free radical damage, because superoxide dismutase is the antioxidant system that will not be functioning optimally. So what will happen in this condition is कि जो spinal cord में anterior horn cells होते हैं. If I just draw a crude diagram related to the spinal cord like this, then we have a reflex arc. Now, like the information comes from the muscle into the dorsal root ganglion. Then there is an interneuron that is present, and then we have is what is called as the anterior horn cell. If I zoom in, I'm talking about this particular cell. This cell is called as the anterior horn cell. This one is called as the interneuron. This is the dorsal root ganglia. And what happens specifically in this particular disease is that the free radicals would be causing damage to this anterior horn cell. Like this anterior horn cell, the damage that I've shown here, you can see the precise damage that is happening. It is occurring at the anterior horn cell, and therefore this entire circuit will not be functioning now. Like normally we have a reflex arc like this, the current can flow to the spinal cord and back to the spinal cord. You can see here that the anterior horn cell, this blue structure that I've shown is called as the anterior horn cell of the spinal cord. This is getting damaged by free radicals. SOD, superoxide dismutase activity is lesser, and thereby lower motor neuron manifestations can occur in this condition. I'll just zoom out and just write the anterior horn cell a little bigger just for reference sake. And because the anterior horn cells are getting damaged, therefore lower motor neuron manifestations like flaccidity, fasciculations would be occurring in a patient. In motor neuron disease, sometimes only lower motor features can occur. Then we call it spinal muscular atrophy. This is when the anterior horn cells are getting affected, but suppose the damage is occurring in the pyramidal neurons in the area 4 of the brain. Like in the area 4 of the brain, we have control over each and every muscle of the body. So if the pyramidal neurons are damaged by free radicals, then we will call it primary lateral sclerosis, where like the corticospinal tract mainly gets involved. And what Stephen Hawking was suffering from was a combo: upper motor neuron lesion plus lower motor neuron lesion. So what will be given in this patient will again be the weakness in the arms and the legs of the patient. Some guys casually still answer as GBS, but here the weakness will be progressing in this patient, not over like few days or over hours. Like when I was describing GBS to you, the weakness was as fast as over 12 hours or over 28 days. Here the weakness will be progressive over number of years. Like this question will say that this patient, like I'm giving example of Stephen Hawking, he was working in MIT, Massachusetts Institute of Technology. Way back in 1975, he started having weakness of his legs. So there was a movie made on him also, that he's having recurrent falls because he's having his neurologist is telling him in that movie that, oh, I am detecting flaccidity and your knee jerk is disappearing, your ankle jerk is disappearing. Like he developed it way back in 1975. He suffered from this weakness in his leg, and while he was doing research on the black hole and astrophysics, he was then having to walk to the university with a cane. He was having difficulty in walking. Then in, let me say, 1976, what happened was that his arm also started having weakness. So the physician is now telling him that I am noticing that your arm is having spasticity, and there is biceps jerk or brisk triceps jerk that is present. Brisk reflexes are coming. So you look at the peculiarity that when the weakness is spreading over 1 hour, it is present in the left leg initially, then in the right arm, and you can notice the huge difference. Flaccidity and absent reflexes are feature of lower motor neuron lesion, and spasticity and brisk reflexes are a feature of upper motor neuron lesion. So they will give you a question in which combination of lower motor and upper motor neuron manifestations will be given together, and that would help you understand that you're dealing with ALS, that is amyotrophic lateral sclerosis. In the later part, even the tongue can be involved, so you could be having tongue fasciculations. These patients could be having involvement of bulbar palsy. In fact, I'll use it black because bulbar palsy is an example of lower motor neuron lesion where the nuclei of the ninth, 10th, and the 12th nerves would involve. What do you mean by the word bulbar palsy is that the nuclei of the ninth and like I'll write it here. Bulbar palsy, okay, is written word. Bulbar palsy means that the nucleus of the 9th, 10th, and the 12th nerve is involved. If these nerves are affected, if the nuclei are affected, then the person will not be able to do these activities. That is, one, he will not be able to drink water, because if you are having a gag reflex and if 9th and 10th are affected, then the gag reflex will be affected. Patient will not be able to drink, he will not be able to eat because tongue plays a role with respect to swallowing, and patient will not be able to eat also. Activities that we don't even think about, no, like eating, drinking, talking. I mean, can't eat, can't drink, and then last is can't talk, because if the vocal cords will get involved, then vocal cord involvement will mean that the person will not be able to talk also, anarthria. So the weakness in Stephen Hawking progressed to a level that he was like, restricted to a wheelchair. This guy gave the concept of black hole, guys. That's a big concept in astrophysics. I mean, this guy was the bap of all the scientists, right? Way back in MIT. That's not a small, getting into MIT is like 10x of getting into IIT Delhi. Right, you can understand. And way back at that point of time, like 1970s, I mean, this was really very, very competitive exam. Obviously now America is more on like, drugs, fentanyl, and America is only fans and stuff like that. But America of 1970s is the main reason why they are so strong now. No, that industrial power that they have is primarily because of the work that their seniors had done in earlier point of time. Anyway, coming back to the agenda, in Stephen Hawking's case, they showed weakness starting in the leg, then in the arm, then there was a development of bulbar palsy, became wheelchair bound, and finally died because of respiratory failure. The cause of death in this condition, the most common cause of death in these patients should be answered as respiratory failure. Here, like, don't answer pneumonia. Unlike when I was describing Alzheimer's, Parkinson disease, and Huntington's disease, there I was mentioning that the cause of death in the patient is aspiration pneumonia. Yeah, aspiration pneumonia can occur here also, but the number one cause of death in these patients is respiratory failure. The workup of these patients will be extensive, like we will do electromyography that will be showing evidence of denervation and innervation, and then we will also be doing a nerve conduction velocity in these patients, in which like no sensory involvement. This is a pure, like this particular disorder, guys, it has a pure motor involvement. There is no sensory involvement that is occurring. You can see it was only motor now. Can't walk, can't hold, like he was not able to do his science experiments because he was having weakness, and he was having spastic weakness in his right arm, and then he was not able to eat. His drinking water is coming from the nose. They all showed it in the movie made on Stephen Hawking, and then like ultimately like he died, but he was the longest living survivor, guys, of this particular disorder, because he told to the medical researchers, you can use my body to test any drug, and these drugs that I'm discussing before you are like edaveron. They have been asked in the exam, so important from the exam perspective: edaveron, riluzole, and tofersen. Edaveron is a glutamate. Remember, glutamate excitotoxicity was present, so it is a glutamate antagonist. Riluzole is a free radical scavenger that reduces the oxidative motor neuron damage. None of them is the drug of choice for this condition. And then is a new drug that is an anti-oligonucleotide. That's an antisense oligonucleotide that targets the mutant superoxide dismutase. So these are like the drugs which are, I would say, in an experimental state. They are not experimental drugs. They have been used in patients and they've increased lifespan, but I cannot say that we can save these patients with a guarantee. So it's still like an emerging science with respect to management of patients of ALS. That is a combination of upper motor and lower motor manifestations that would be given. If they ever give you upper motor and lower motor manifestations together, either think of vitamin B12 deficiency, because in vitamin B12 deficiency there can be peripheral neuropathy and there can be damage to the spinal cord as well, where like corticospinal tract demyelination can occur. If you ever read a question in which combination of upper motor and lower motor manifestations are given, then what are the differentials that you should be thinking of? From pediatrics perspective, the disease is called as Friedreich ataxia. From the pediatrics perspective, the disease is Friedreich ataxia. This having a frataxin gene. So just remember Friedreich ataxia as a name, combination of lower motor, upper motor, and has even cardiomyopathy, even as diabetes mellitus. Then is vitamin B12 deficiency, because in vitamin B12 deficiency, you can be having peripheral neuropathy and you can be having demyelination of the corticospinal tract. And then is obviously the unmistakable topic that we're discussing, which is called as ALS, that is amyotrophic lateral sclerosis. Next, I'm describing a patient who's having central cord syndrome. Central cord syndrome would mainly be like impacting this particular area. Like this person is relatively old in age. He was sitting in the back seat of a car that was being driven by his daughter. And unfortunately, like his daughter suddenly applied the brakes, and because some other vehicle stopped at middle of the highway, and this guy was not using a seat belt, so there was like a sudden jolt to the neck of this patient. That forced hyperextension of the cervical spine can result in a central cord syndrome, and this can result in damage to the following tracts. Let me highlight these tracts before you. The one that I've currently highlighted, this where I'm writing, like this is cervical fibers, then is thoracic, then is lumbar, and then is sacral. This yellow fiber that I've currently marked before you is called as the lateral spinothalamic pathway. This carries the sensation of pain and temperature. So because in this particular patient, this lateral spinothalamic pathway will get involved, therefore the manifestations would be in the form of loss of pain and temperature. The lateral spinothalamic pathway carries pain and temperature. Then the green structure that I've shown here before you is called as the corticospinal pathway. Corticospinal pathway involves controls each and every muscle of the body. So if this would be involved, there would be like weakness developing. Initially, like the guy can develop a spinal shock, and subsequently, like I can say that in this person, the manifestations of spasticity can begin to appear, but you can see a pathway in red that is present posteriorly. This is usually spared. This is the one that is called as dorsal column, and this is what they asked in the exam, that what is the sparing that would be seen in this patient. So the sparing that would be seen in this patient would be the dorsal column. Dorsal column carries two sensations: proprioception and vibration sense. What do you mean by proprioception? Is joint and position. Like if I say to you, can you feel your ankle joint? Can you feel your knee joint? Yeah, you can feel your knee joint or ankle joint. So that sensation of your knee or ankle joint, you don't need to look at your foot. No, you can feel your ankle, foot touching your ground. You can feel the big toe of your right foot. You can feel the little finger of your right foot. Can you feel the little finger of your right hand? Yeah, you can. I mean, you don't need to look down at it. So proprioception, joint and position sense. And suppose you are in a live class, you might be keeping your mobile phone on a vibration mode just in case you are getting an urgent call. You don't want to disturb others. So this sensations would be preserved, because in the central cord syndrome, what happens is that mainly it's gonna be like the areas which are in and around this area. This is the central canal. This is where the CSF would be present, and central cord syndrome, as the name suggests, can be involving the fibers in yellow as well as the fibers in green. And because cervical fibers would be involved first, because the circumferential force is expanding, so cervical fibers are involved first. So the upper limb weakness, cervical fibers means upper limb involvement will be more than the lower limb involvement that will be occurring in this patient. And then bilateral pain and temperature loss below the level of the lesion. Most of the time it's the cervical spine getting involved. So below this pain and temperature loss would be present. Vibration and proprioception will be preserved. This in MCQ was deliberately written as absent. This would be preserved. And then I can say that because the force is expanding due to sudden hyperextension of the spine from inside to outside, so cervical fibers will be more injured as compared to the sacral fibers. So therefore sacral fiber sparing can be present. Even for the corticospinal pathway, I'll zoom it in. Even for the corticospinal pathway, it is the cervical fibers which are present most medially, and it is the sacral fibers which are present most laterally. So you can see like this border where the central cord syndrome is having impact. So that is why, like I'm saying, sacral sparing can be seen in this patient, especially with respect to the motor impact of this condition. The description that I gave was called as central cord syndrome. This is not to be mixed with what they teach you in physiology with respect to Brown-Séquard syndrome. That is hemisection of the spinal cord where the contralateral pain and temperature is affected once level low. So I would suggest you to read Brown-Séquard syndrome from physiology component, where it is a contralateral, but I'm saying it anyway. In Brown-Séquard syndrome, it's a hemisection of the spinal cord. Let's do it here only. Hemisection मतलब ये यहाँ पे कट गया ऐसे. If this is the damage present, then on one side dorsal column will also be affected now. So he will say ipsilateral proprioception loss that is happening, and corticospinal pathway is anyway gonna be affected. Even lateral spinothalamic pathway, which is carrying information from the opposite side, would be affected. So there is a contralateral pace and temperature loss that is also. Damage is occurring on this side, but contralateral pain and temperature sensation is also affected because the information into this yellow fiber comes from the opposite side also. So Brown-Séquard syndrome manifestations would be, I'll write it down in few seconds, would be contralateral pain and temperature loss also, which would not be happening with respect to this presentation. Here it's a bilateral, man. Here it is a bilateral pain and temperature loss, bilateral corticospinal tract injury, and predominantly cervical spine. The sacral fibers bahar ki taraf hote hain. That's why he says the word sacral sparing, and there is no dorsal column involvement present in this case. In contrast, if I say syringomelia, Syringomelia is a condition in which the central canal will expand. मैं इसको थोड़ा सा modify करता हूँ, अभी कुछ भी change नहीं करना. If this central canal will increase in size, then it can go and press on this lateral spinothalamic pathway, na? And if the lateral spinothalamic pathway में cervical fibers would be affected, then what sensation would be lost? Pain and temperature. So the clinical manifestation of this condition would be कि hands में ना pain and temperature loss will be occurring, and this patient might be cooking food for himself. The hand may touch the hot plate, but in spite of hand touching the hot plate, patient will not feel any burn. Guys, in syringomelia, the manifestation is very, very peculiar. Painless burn in the hand. You will not read. Burns are painful, man. You ever are cooking Maggie for yourself, tea for yourself, there will always be like pain present. Painless burn in the hand is occurring because the cervical fibers are getting involved here from the medial side. So therefore, when it comes to syringomelia, the cause of this is like multiple. One of them is called as Arnold Chiari malformation type 1. That is just one of the facts to be remembered. Arnold-Chiari malformation type 1 is the most common cause for development of pharyngomelia. So it's a developmental malformation. But what are the manifestations? There are two that are to be remembered. If you ever read the word painless burn in the hand, that's always a feature of pharyngomelia. It could be one, it could be bone hand, because the central canal will expand asymmetrically. And second would be that mainly the cervical area. You can see that the arms of the patient, these are all cervical areas. That would be, cervical, spinal cord. This C part that I had written is the one that is getting involved. So pain and temperature sensation will be lost in a cape distribution. That cape is like a cloth now that you are wearing, like Superman wears a cape basically. So he might say that the temperature loss, there are two sensations that are being lost here. What are the sensations? Temperature loss and pain, and the loss of them in the arms of the patient, because cervical fibers are the first one to be involved. Sacral are usually spared, so bladder bubble involvement will not be seen, but temperature and pain loss is occurring in a cape distribution. These are like two very cliche classical terminologies that can be given for this developmental malformation of the spinal cord. In contrast, when it comes to Brown-Séquard syndrome in a patient, Brown-Séquard is always due to trauma. We call it a hemisection of the spinal cord. The hemisection of the spinal cord, the two main manifestations of this condition will be that because the spinal cord is cut into half, then on whichever side it is cut, ipsilateral proprioception loss will be seen. The reason for this is primarily that the dorsal column of the patient gets affected. But at the same time, there is a opposite side. The patient is also educated. He says, how is it possible that opposite is occurring? That's because the yellow fiber that I had shown to you, the corticospinal path, that's the laterospasmothalamic pathway, is getting input from the opposite side as well. So contralateral pain and temperature is loss would be seen in this patient, and this loss will be seen usually about almost like 2 levels below. Like suppose the trauma is occurring at T4 level, then it is at T6 level, opposite side of the body, that pain and temperature loss would be present in a patient. So Brown-Séquard syndrome is basically hemisection of the spinal cord. In clinical practice, that precise hemisection does not happen. In routine clinical practice, we don't have like symmetrical damage that is present. So this I have written just for the sake of completion. Because the notes I want to be perfect, so I'm just removing this because I would like you to read about it from the physiology domain. From medicine perspective, what we have to remember is pharyngomelia, developmental malformation for which decompressive surgery would be required, painless burn in the hand, and temperature and pain loss in a cape distribution would be given. Central cord syndrome is like sudden hyperextension of the spine in an old man, like his daughter was driving, suddenly slammed on the brakes, and then you get this manifestation of like that expanding circumferential force, which will affect the yellow fibers as well as the green fibers respectively. Explained to you the yellow and the green ones. And the sacral sparing is one of the characteristic features. Dorsal column sparing in this condition is again one of the characteristic manifestations. Prior to this, I have described regarding that peculiar disorder where combination of upper motor as well as lower motor manifestations are present. This is not a routine thing, sir. That's why I'm highlighting it once again, because all through the discussion, I've been like particular about like what is the lesion that is present. This is a combo lesion, Friedreich ataxia, vitamin B12 deficiency, and amyotrophic lateral sclerosis. Let's do a question here to wind up the discussion. 35-year-old woman presents with limb weakness and muscle wasting for past 1 year. Tongue fasciculations are given, hypertonia in the arms is noted. So you can notice two things. Wasting is a feature of lower motor neuron, and hypertonia is a feature of upper motor neuron. He's himself saying she's diagnosed as amyotrophic lateral sclerosis. What will be the finding that will be seen? So Lewy bodies are what are seen in Parkinson disease. Hirano bodies are seen in Alzheimer's disease. Only left between Bunina and Lafora bodies. Lafora bodies are seen with Lafora syndrome, which is the cause of epilepsy. Some questions would be like this also, that you would have never read about them. So here I have introduced one term, Lafora bodies in Lafora's disease, which is an epileptic syndrome. The answer to this question is Bunina body. So some questions obviously have to be like sorted out, because this is not biology, guys, right? This is medical science. So you have to do analytical skills. And I think that if you've reached the end of this video, it's a phenomenal task that you're doing. If I was your age, I would have not reached up till the end here. I would have somehow skipped topics, and I would have honestly not been like so, I would say, honest as you are at the moment, if you have listened to the whole thing, right? So if you're skipped in between, guys, go back, listen to the whole thing. Just give me whatever, like, few hours that I've taken in your life. I mean, dedicated to neurology. And I can assure you that if you just keep on doing practice of this data, you will be able to break onto the other side. Take care. God bless you.